I have one more, and this is for the private payer side. Most of the discussion today about the per member per month and the pools and everything is focused on Medicaid and the timeline. On the private payer side, one, is there a timeline? Two, how are the pools going to be defined, because we currently don't have a defined panel of patients with most of our private payers like we do Medicaid, and so on and so on. I think you get the drift.
Sure, and that's a great question. Just as with the episodes, participation in certain aspects of the Arkansas Payment Improvement Initiative is on a payer-specific basis. We are going to have to do an analysis, and we've started doing that, to determine whether the volume of pediatric patients that we have and the cost of those pediatric patients are worth creating a meaningful incentive to pediatric practices. We don't know that at this point, because the demographics of the children that we insure we think are much different than the demographics of the people that Medicaid insures. So it may be that we don't engage in pediatric medical home as quickly as Medicaid does. Now, all that changes if there's a vote tomorrow or sometime soon that says that, you know, Medicaid is going to expand, and there's a potential that someday, I guess, part of the Our Kids program could go through that. I mean, there's nothing to guarantee that. But if that does happen, then the demographic of the population that's served by the private payers changes, and we probably have to reevaluate.
Go ahead.
If you don't mind, I have a couple of questions. I'm Darlene Bird, advanced practice nurse with APN Healthcare. Will every patient in a practice be a member of the medical homes, or will membership in medical homes just be for patients of a high-risk category? This is similar to questions, I mean, kind of like North Carolina has their members so many disease processes before they were members of the benefits of the medical home. Other question is, how is all this going to fit into the health exchange and the privatization of Medicaid? How will things change with this if we go that route after the Senate vote? And two, I mean, the third one is, will it take legislation or administrative rules to implement the medical home model?
So let me just answer one of your questions, and then we can just move on. No, I'm just kidding. We'll try to get to all three of them. Every patient a member, yes. This is not just focused on high-risk patients. No. In part because the focus is on prevention. And we hate to just wait until someone is revealed as a high-risk patient to manage their care. Prevention is at the core of this, both primary and secondary prevention. Does this fit into the private option? Absolutely. So I read to you some language from the private option bill, and that was a very interesting progression in the conversation with legislative leaders who, over the course of the session, came to adopt and own and openly advocate on their own for the patient-centered medical home. The crafters of this bill, the sponsors, the chief authors, are out there selling and promoting the patient-centered medical home as a core in the reform of healthcare, not simply the coverage issue. And so right into the bill is the requirement that qualified health plans serving on the exchange, all of whom will have to accept those funded by Medicaid, because we're not going to tell them who's who necessarily. It's all in. This is private. This is not Medicaid in the exchange. They will all be participating. If you have a Medicaid-funded individual, the expectation is they've got a PCP, and those payments are there, and they're participating, as well as the reporting requirement, which is such an enormous component of this. So yes, we knew, the crafters of this bill knew that it was important to lay that out, in the legislation, and to directly attach reform of the system to any expansion in coverage. So that's explicit. Does it fit in? Yes, we think that it very strongly fits in. It does mean that the exchange will need to have a role in actively participating and supporting these tenets, because the Medicaid program will not be able to just directly dictate what goes on in the private market. This is not Medicaid in the exchange. This is the private insurance market, and I don't happen to run that, and nor will I in the future.
Just building on Andy's, I'm looking at the bill. It's subsection D. It requires that participating plans assign primary care providers, support patient-centered medical homes, and support access of clinical performance data for providers to be able to manage in the medical home. Those are the three things written into the legislation. The process by requirement will be through the certification process of the plans to participate on the exchange. I just go back to echo what Andy said. It's not going to be a Medicaid rule or Medicaid regulation that guides this. This is the private market setting up its best innovative way to respond to the legislative requirements for a successful patient-centered medical home. So I think that's where the innovation is. I think that's where some of the excitement is on the more conservative end of the political spectrum. And I think that's where some of the national attention is with respect to us doing something in a different way.
You know, when you think about the future of all of this and how it will evolve, we've all kind of thought about that kind of thing. And from a medical home perspective, yes, right now, at the forefront of the ability to receive care coordination payments and shared savings and things like that is the primary care physician. But frankly, I think as this concept evolves, those primary care physicians are going to understand the value of other primary care providers who aren't physicians and be willing to set up shared incentive programs with those other providers of care. So when you talk about chiropractic, or you talk about pharmacy, or you talk about other different parts of the system, I think the incentives will create an evolution in the delivery system to create integrated care teams. Now, they don't have to be legal entities. They don't have to be financially integrated, but they certainly can be process integrated and create a situation where they can share the fruits of their labor. There are going to have to be some regulations and laws that are addressed, like the Stark provisions and things like that, that sometimes get in the way of being able to share things like that. But I think the evolution of this will call for those things to be addressed so that there can be equitable sharing based on the input of a lot of different parts of the system that provide primary care.
Now go ahead and answer your last question, Darlene. The administrative rules process. Yes, for Medicaid, it will go through the administrative rules process. Our timeline is just over a month, we'd be submitting our proposal to CMS, Centers for Medicaid and Medicare Services. And also we would be submitting for initiating the Administrative Procedure Act process, in which we would publish official notice and the proposed rules.
Hi, Kevin Cullinan with St. Vincent. The quoted PMPM, is that, you said it's an average, is that an average across payers or an average across risk levels once people are risk stratified? And I ask that just because of our experience with CPCI.
Data I was showing you related to our Medicaid planning. So it would be risk adjusted across the patients that we see in our program. Each payer would have their own mechanism of doing that. Does that answer your question? Thank you.
We're in our last 10 minutes. Do we have additional questions? Any parting comments from our panel?
I would say with you, I think this is an exciting opportunity for primary care and for the teams of folks that our citizens need to provide their care. This is not like a patient-centered medical home that you're going to read about somewhere else. This is actually on the front edge, kind of putting it together in a very different way that actually is taking advantage of, as Andy alluded to, some of the bumps in primary care payment that are in the Affordable Care Act, some of the opportunities we have through the potential for Medicaid expansion, and based upon some of the work that has been underway, I have been impressed, again, if you go back to that risk sharing, as opposed to the state turning to an outside managed care company to come in and try to contain cost. What the payers, public and private, have said is let us retain the actuary risk, which is what their job is, and let us partner with clinical providers to manage the patients, which is what the provider's job is, and let us share in the savings that come from that, because both sides know that the current system is filled with inefficiencies, with lost opportunities, and with costs that can be avoided. So I think this is really a 21st century opportunity for a new payment design, and I look forward to building it with you and learning along the way. So thank you all very much, all of you, for being here this afternoon.